Hi, my name is Dan Sciubba, and I'm the professor and chair of neurosurgery at Northwell Health and Hofstra University. We have a health system that's based throughout Long Island and New York, and today I'm going to speak about spinal tumors, what everyone should know. This is something that's near and dear to my heart as I've worked my entire career on taking care of patients with spine tumors and doing research and education on the subject. I hope this is helpful. And we're going to go through some big points about what people should think about when they think about spine tumors. These are some disclosures that I have, just to be completely transparent, that I do have relationships with multiple entities, none of which I think really are relevant to this talk, but nonetheless, they're presented here. When we think about cancer cases in the U.S., they're increasing every year. And the issue really is that we're living longer. And so the longer we live, the more chance we have that we can get cancer. So although the numbers are going up, this is a sign really that we're able to have patients live longer, and obviously they succumb to more diseases. Nonetheless, that number is quite staggering when you look up there and say new cases. This is not just cases of patients with cancer that you may know in your family or your friends. These are new cases coming out every year. When we think about patients with cancer, it often spreads to other parts of the body. It can spread to the liver, it can spread to the lung, and it can spread to the skeleton. And when it spreads to the skeleton, the most common site it spreads to actually is the spine. And so when we think about some common cancers like breast cancer, myeloma, lung, prostate, and renal cancer, or kidney cancer, these are the types of cases that are presenting with metastatic spine tumors each year. And when we look at this, we actually see that there's probably over 1 million in this country of new spine tumors. Just to give a sense of this, this is over 10 times more than any brain tumor. So when we think about people getting brain cancer or brain tumors, spine cancer and spine tumors are far more common. And when that happens, not only do we have to worry about the cancer aspect of it, but we have to worry about what it does to the patient beyond the life-threatening aspect of cancer. Overwhelmingly, as you can see in that left chart, pain accounts for 90% of the presentation, meaning that patients present with often debilitating pain. And the neurological deficit, and what does that mean? That means anything from walking problems, to arm issues, to holding things, to bowel and bladder issues, to balance issues, to sensory loss. And so this can be significant. 75% of people present with a new problem where their function is not normal in addition to pain. So it's a big deal. Patients often ask, and as anyone, as I would if I were a patient, what should I do? And the issue is that it's not a simple answer for each patient. In fact, there's multiple variables, and we can go through what we call algorithms or best practice to really define what's probably best for the majority of people, but it still comes down to the individual patient. And so, although you may ask me about my function, my pain, and my age, and all these other things in my medical history, it's still going to come down to what Dan Sciubba feels is the best for him and his family at this point in my life. And so that's something, as much as we go through the next few slides to talk about what's important, it still comes down to what's going on in the heart and mind of that person and their family. Sometimes they ask me, what should I do? And sometimes I tell them at the end of a long discussion, and then they say, okay, now that I've asked you that, what would you do if you were me? And the answer really is the same, right? I'm giving the advice that I would want someone to give me. And if they don't happy with that, they always say, what would you do if I were your mother? Again, same idea. Obviously, my mother's a different patient than me, so we would have different parameters. This patient is specific to them, and the goal is to give them the best information for them at that time in their lives. For me, I've used this term quite a bit, and this is probably true not just of spine tumor care, but also of life in general. Where's the sweet spot, right? And the answer is, you know, that famous line, you can have anything you want, but you can't have everything. And the issue is there's trade-offs in life. And some people think a sweet spot, maybe if they play golf, maybe if they play tennis, there's a sweet spot of the club or the sweet spot of the racket. Sometimes people talk about life and they say the sweet spot of life is when you're good at something and you like something, so that you find your sweet spot when your strengths match your passions. Other people say their sweet spot is wine because it matches science and art, and obviously I think there's other reasons they like wine more than just science and art. But the idea is that for a surgeon, there's got to be a sweet spot when we think about patients. We can't all push them to the red line. We have to sit there and say, what is really the perfect area in the middle? And you're going to give trade-offs. So for example, one side for me as a spine tumor surgeon would be, I want the maximal tumor resection. I want to get the tumor all out. I want it to be stabilized so the spine is rock solid and the patient is stable in that way. I want the alignment good so they stand right, so they move around right. Now you can push that and push that and push that and make the surgery longer and longer and more complicated. And as you can imagine, the more you push that and those things that you really want, as a surgeon, you may actually take away something from the patient. More risk, more time in the hospital. So the other side is what I would call what's surgically safe and what's value to the patient or what's satisfaction. So you can imagine if you don't hang out in that sweet spot in the middle where you're thinking about both, if you only think about what the surgeon wants, you may actually put the patient through significant, long and challenging recovery. If you only want what the patient wants at first blush, the patient may say, I don't want a surgery at all because I don't want to do that, or I don't want to take these medicines, which may not be the best for them because then they'll lose the ability to benefit from those. So it has to be a combination of the two. Let me give you an example. And before I do that, the idea is the truth of the matter, the sweet spot is, and from the famous movie A Few Good Men, can you handle the truth? The truth is, as I already alluded to, is nothing really is perfect. So as you talk to patients, and as I'm a patient, I have to understand that there's going to be some trade-offs as we try to get to that perfect sweet spot. And the reason I say is because the Venn diagram between those two graphs, trying to find the middle part, is probably 4 or 5 circles all overlapping that we have to think about. We're going to go through those. Let me give you an example. This is a patient where maybe too little was resected. They had a surgery of a large type of tumor at the base of the skull. And they said rather than go through a very large surgery with potentially long recovery, they said let's just do a little one and then see how it goes. And the tumor continued to grow because it wasn't removed. And here's a radiograph or an MRI scan of a tumor with at the skull base now invading into the spinal cord as a result of really not taking it enough out. And unfortunately, this tumor doesn't respond to chemotherapy and doesn't respond to radiation therapy. So what happens is that this patient now stuck with maybe I would call a weed that they didn't take the whole root out of the weed and they just took the top of the weed off, and the weed now grew into multiple new weeds, and this is a problem. And so this was probably too small. On the other hand, here's a situation where maybe too much was resected, if you will. This is a patient where I was called by a colleague of mine, and these are a number of pictures, and not only showing the tumor on MRI and showing the intra-op photo with the tumor removed and reconstructed, but also the x-rays afterwards. And they were very proud of this and said, we nailed it. We got it all out, and it's all reconstructed, and all these pictures look beautiful. And this was sent to me, and all the pictures are beautiful from a surgeon's point of view. The only issue is the patient ended up being extremely weak after surgery and is having problems walking now because they really put them through too much. So now this patient is sitting there obviously saying, I don't know if I would have gone through that again because I can't walk as well. So was this too much taken out? Was this too big of a surgery to accomplish the goals that the surgeon thought were good to get that whole tumor out, when in reality maybe something else was sacrificed? So these are the balancing areas that people should know. We're going to go through them individually. And these are the ones that I think should guide us. There's 5 things. I know it's a lot of words here, but they're really 5 things. And it's like any decision in life, whether it's a relationship, whether it's buying a car, or whether it's playing a sport, you're not just looking at one variable, you're looking at multiple variables in order to navigate your way through a situation. So what guides us? Obviously, I alluded to before, spinal cord compression guides us, right? If the tumor is pressing on the spinal cord and causing a neurological deficit, again, what does that mean? Weakness, not be able to move your legs, not able to walk, not able to stand, be in a wheelchair, not able to move your arms, potentially. Bowel and bladder issues, not able to urinate. Having not been able to hold your stool in, loss of sensation, pain, right? So this spinal cord compression neurological deficit guides us. It's a fact, it's at the top of the list. Instability means if the tumor has eaten away the bony spine, the skeleton of the spine, if you will, the bone of the spine, it can cause significant problems, and the main one is pain. So for example, say I'm sitting here and God forbid I have a tumor in my spine and it's not making me weak in my legs, but it's eating away my spine and my spine is broken, I may actually have the inability to sit here without being in excruciating pain. So obviously the first one is not the only thing. Instability matters too. Local tumor control is, again, how do we get that whole tumor out if it is a solitary tumor, meaning if it's a single tumor and not metastatic. Again, metastatic means the tumor has gone from, say, the liver to the spine. So there's a tumor in both the liver and the spine. There's 2 tumors. So if you obviously took every bit of the tumor out of the spine, that might be really good for the spine, but there's still tumor in the liver and maybe other parts of the body. So you can't necessarily cure someone with metastatic disease with surgery alone. But if it's a local tumor, meaning just one tumor in the spine, and it doesn't respond to radiation, radiation resistant, the goal is to get that whole thing out in one piece. That's number 3. Number 4 is debilitating deformity. And deformity means anything from a scoliosis to a pitched forward posture to not being able to stand up straight. So again, this is different, right? Because say, I don't have any spinal cord compression, I don't have any instability, the tumor is controlled, but I'm left bent sideways and I can't stand upright, or my neck is bent forward where I can't look up to talk to people or look to the sun, to the horizon. Patients really don't like that. So if you tell a patient, hey, listen, we got the tumor out, it's controlled, it's stable, but you're looking at the floor and can't look up to talk to someone, it's a problem. And then finally, one thing that is separate, but it really involves all the others, is the idea of survival, meaning what are we giving the patient? Are we giving them something that will last a long time? And also during that time, will they be satisfied? All right, so that's really the question of quantity and quality. And people always say things like, I'd rather have quality than quantity when I talk to them about regular stuff in life, but the answer is we want both, right? We want time and we want good time. And so this is something that's becoming much more of an issue in research, in my field and the research I do, because what I don't want to tell a patient is, hey, listen, you got a great operation, and they don't think so. They sit there and say, well, I'm not very happy. I say, no, you got a good operation because I did 1 through 4. And they say, well, it didn't actually match what my goals were with my life and my family right now. So that's extremely important to understand where they are in their lives and what they're looking for before we put all the other stuff on top of them too. Let's start with spinal cord compression neurological deficit. This started years ago. This question started years ago when people with metastatic tumors, maybe a tumor from the kidney that went to the spine, and a lot of people said, don't ever operate on that. Listen, the tumor's already in the spine. Let's just radiate and do the minimal possible, because don't put this patient through much. Put them through what we call palliative treatment. Don't even try to do much. Even all those things I talked about just now, don't try to do that. Just let them be, and we'll try to do something for the short term. And what happened is in the 80s and 90s, people started really operating a lot on these tumors. And there was a discussion that some people felt it was wrong that surgeons were being aggressive because the patient had cancer throughout their body. And on the other hand, the surgeon said, no, we're helping them. And this came to really a head in the 2000s, and I'll show you the paper in a moment, where they said, let's do a study. And the researchers thought that radiation alone would be better. And they actually set up a study and said it's going to be so obvious that radiation alone is better than surgery. And surgery ended up being the right one, and actually they had to stop the study early because surgery was so clearly better for these patients that they didn't feel it was ethical to continue the study and keep randomizing people to one or the other. They said, we got to stop it. And here's a study. It's a lot of words here, but this is the famous title of the study called direct decompressive surgical resection in the treatment of spinal cord compression. And this was randomized. And this was known as the Patchell study in 2005. And this really changed the field to say there are people who can really benefit. Now, this is a complicated slide, but bear with me on this. And the top word says NOMS, and this is similar to what I talked about, N-O-M-S, neurologic, meaning what's their function, what's their spinal cord function. Oncologic, what's their tumor, because the tumor matters. A renal cell cancer versus a myeloma matters if it goes to the spine. Mechanical, that's the instability. And systemic, how healthy is this patient? Can they undergo a surgery? And so this picture really has 4 different pictures, 0, 1, 2, and 3. And right in the very center is a circle, which is your spinal cord. And the 0 picture has a tumor that's just off to the side, not pushing the spinal cord. And number 1 has a tumor that's starting to push on it. And number 3, you can't even see the circle because the tumor is completely around it. I'm sorry, number 2, that is. And number 3, it's actually squished the spinal cord so much that it's squished sideways, if you will. And what one can imagine is the 0, the patient's legs work fine. Number 1 also. Number 2, maybe they're starting to have some symptoms. And number 3, they're probably very, very weak. So you can imagine, based on the presentation of the patient and these pictures, we're going to be more aggressive with number 3, and we're going to think about things in 0 because we can. So the case is that if all these are radiation sensitive, something like myeloma, we could probably zap all of them. In about a week, the tumor would be gone. Now, in number 3, maybe you wouldn't do that if the patient were really weak. You wouldn't necessarily want to wait. You might want to operate on them. But in general, if it's radiation sensitive like myeloma, at least 0, 1, and 2, a lot of us would feel comfortable saying, let's radiate this. Patient goes into a a box where they get radiated for a little while, and they have a couple treatments, and they are free of tumor maybe down the road. But the majority of tumors that go to the spine are not sensitive to radiation. They actually have to have a surgery. And so those bottom 2 and 3, definitely, like I said, if they're not radiation sensitive, definitely need a surgery. 0 and 1, sometimes we can use a special type of radiation called focused radiation. It's called spinal stereotactic radiation, or focused photons. There's also proton beams. And you could, in 1 and 2, since that radiation is so much stronger, you can zap the tumor if it's not right next to the spinal cord. So again, if the tumor is wrapped around the spinal cord like tentacles, you're not going to be able to zap it with the high-dose radiation because you'll hit the spinal cord the same time you hit the tumor. So those need surgery if it's radiation sensitive. While if it's off to the side, one can increase that dose of radiation. So in summary, if it's radiation sensitive to regular radiation, can treat, in theory, all of them if the patient's neurologically stable. If it's not radiation sensitive, you got to use that strong radiation, but only if it's not near the spinal cord, because that strong radiation will hurt the spinal cord. So therefore, in 2 and 3, you're really forcing the patient to consider surgical decompression and then radiation afterwards. Maybe after that tumor is taken out and they radiate the tumor bed to make sure every single tumor cell is gone. Instability, again, is interesting because this was something that really came out of the minds of surgeons. So for example, the last issue came out not only from the minds of surgeons, but really from oncologists, right? From the oncologists and the radiation oncologists saying, this is what's needed. We can radiate this one. They know it better than I do. I'm not a radiation oncologist, although I've learned from them. And the medical oncologist might say, no, this is the type of tumor, this is how it's going to grow. Again, can it respond to chemotherapy and melt away with that? Again, I've learned a lot from them, but I'm not a medical oncologist. But instability really has been in the hands of surgeons for years because they're the ones who put the spine back together with screws and rods. And they're the ones who can have probably the best sense of what is unstable. Unfortunately, sometimes that doesn't travel, right? It's like any expert where they sit there and say, yeah, I think you need this. Why? I just feel that way. So instability was also this very ambiguous comment where people would say, how do you know? So a number of years ago, a number of specialists got together, and these were surgeons, both orthopedic and neurosurgeons who do spinal operations, radiation oncologists and medical oncologists, and said, let's think of a way that we can translate this so everybody understands what we're thinking when we think of instability. And the idea was this quote, and the quote was really loss of spinal integrity, whatever that means, but enough so that it made one weak, in pain, or starting to get deformed, meaning their spine started collapsing. So, and this is of course from a tumor. So if one had a spinal tumor that was very small, like the size of a grain of rice, and wasn't doing any of these things, it wasn't unstable. If it were so big that it had broken away that broken part of the spine and the patient was either in incapacitating pain, their spine was bent, or it started encroaching on their spinal cord from the instability, we would call that instability. That's great. Again, that might not translate, so we wanted to really codify this and say, can you give me a number? Can you help me, tell me how it's really unstable and what's not? And what we did, and this is a very busy slide, it's not meant to do it, but it showed that we went together and we thought of all these ideas, location and pain and alignment, and we gave points to this. And the whole point of this is this is now automated for us and for specialists throughout the world, and there's an app that you can do now where you basically put in like a little calculator, and we put in the numbers, and we can tell a patient, hey, do you fall in the stable range, the potentially unstable range, or the clearly unstable? So if there's a doubt, or if the doctor is not sure, or the radiologist is not sure, we can use this. And this has been reliable across all fields, across not only the surgeons, but the radiologists, the radiation oncologists, and others. So let me give you an example. Here's a patient who presented to me, and she had a tumor at the bottom of her, basically in her tailbone, a little bit above the tailbone in what's called the sacrum. And the sacrum is named that for sacral bone. It's a very important bone. It holds the entire spine and allows it to be the keystone between the spine, the torso, and the pelvis. So as your spine goes down to your pelvis, there's a big triangular bone called the sacrum. And it was very, very large, and she said, some people are telling me I don't have to do anything, maybe just radiate this, and other people are telling me I should have surgery on this. And as she's driving down to meet me at my office, she has a terrible pain syndrome where she's got pain radiating into her leg. So we got a new picture, and this was even worse than the one she had maybe a month before. And based on her pain, based on what I looked at, I said, this is unstable. You're going to need to have screws in your back. But if I was unsure, I could use this app and really add up all the numbers about her, about why I think it, and this came out to be 15, which is one of the highest numbers you can get. So if I were unsure, I could do this. And this is an advancement that we've done to be able to translate to patients and to people across the country, hey, just give me what we call the SIN score. And if they give me a SIN score, I say, listen, independent of what I think, there's a score that says this patient's probably going to need to be fixed. And so she did. She got x-ray, she got screws that went in her back, and she was able to walk the night of surgery, and she was able to walk to the hospital where she was incapacitated with pain and weakness before that. Here's another patient, it's an MRI scan showing a patient with a history of breast cancer, and the grayish body amongst the bones is the one where the tumor is, and it's involving almost the entire bone, but the patient really had no pain. So this is a patient who had very little pain, and this picture, and they said, well, maybe we can just radiate this alone. Now, this patient was sent to me after radiation, so I didn't see these pictures till later, but when I looked at the CT that was done, this really had eaten away most of the spine. And although she wasn't in incapacitating pain, the idea of radiating that, which will somewhat weaken that bone, right? It'll kill the tumor, but also weaken the bone. My fear, looking back, of course, would have been that this may be a setup, right? This is what I would call a precarious situation where maybe she's stable now, but maybe she's right on the edge of the cliff. And if we radiate her, it might fall off. I didn't meet her till after this, but that's what was done. And she was radiated, and she was, again, happy that she didn't have to go through surgery per the people that saw her. But then, and if you wanted to look specifically at her SIN score at this time, it wasn't completely stable. You add up those numbers. It was potentially unstable. She was right at that cliff. This is why it's important to look at all these things. So she underwent radiation, and then what you can tell here maybe is if you look right in the middle, she's got these squares, but right in the middle now it's collapsed. So now her spine has broken in that area just a month after she had radiation, and now she's in incapacitating pain. And I'm not saying anything was done wrong here, and no one can predict the future, but this tool actually kind of said she's on the edge, and now, of course, when you look at her SIN score, she's clearly unstable based on her numbers. And of course, she then underwent a surgery to stabilize this. Now, could this have been avoided? Maybe, maybe not, but the idea is that giving that patient as much information as possible to make a decision saying, we can do the radiation, it might be easier now, or we do a surgery now so you don't have radiation and surgery in that order, maybe the way to go, is something that we have to give the patient and their family the options for. And again, no one can tell the future, last time I checked, but we're getting better at predicting things, and we want to be able to give that information to our patients. In terms of what that means, here's a paper, and the big number is that 13.9%. What we're finding is sometimes when we give that really high radiation dose, which again, this is back to my trade-off comment. You're giving something, and there's always a price to pay. So you give a higher dose of radiation, people say that's awesome. More tumor control, more killing of that tumor. Maybe we can zap it off the face of the earth, but it also obviously takes some collateral damage. It sometimes hurts the bone and the soft tissues. So what we find here is in this study, there are about 15% of people who are deemed stable and had a fracture later on, and then maybe they need surgery later on. So can we avoid that? Maybe sometimes we can put cement into the vertebral body at the same time or right before the radiation is done, which is really done by a needle. And if that bolsters that current situation where the spine, what the spine looks like at that time, and then one radiates it, the cement holds it in place regardless, and they don't fracture and maybe need a surgery to reconstruct them later. So this is something that's changing the way we think. And this comes out of research, and it comes out of experience, and it comes out of talking to other people to make sure they know what the best is for each patient. In terms of local control, this is something where patients will say, can you take the tumor out and cure me? Now, if it's a primary tumor, it's not metastatic. Let me go through that again. If a tumor starts in the kidney and goes to the spine, that's called metastatic. It's jumped from one organ to the spine. So therefore, if you cut everything out of that spine, you take the entire spine tumor out of the spine, you haven't cured the patient because they have maybe a kidney cancer still, and there might be other lesions elsewhere. So the surgery, you tell the patient, we got it all, and the patient will say, did you cure me of my cancer? And you say, well, no, we maybe cured you of that tumor in the spine, but not of cancer in your body. However, if the tumor starts in the spine, called what's called a primary tumor of the spine, it primarily started in the spine. It didn't come from the kidney, it came from the spine, and the only place it's in your body is in the spine. One could argue if we get that out completely, one can be cured. In addition, some of those tumors are actually really hard to treat with radiation. The radiation doesn't do anything to these tumors. or we have to use a very, very high dose of radiation, which sometimes works, but often has left the patient with other side effects from that high radiation. So the idea is in these tumors, we have to treat the patient differently. And so sometimes when I talk to patients, I'll say, we have to take a picture of your spine and of your entire body. If I only find one tumor, the goal might be cure. If I find that they're sent to me from a kidney doctor who said they have kidney cancer and they have multiple lesions in their spine, I say, our job may be to get all that tumor in the spine, but when that patient wakes up, the surgery went great, you're stable, everything's decompressed from the spinal cord perspective. But remember, you still have cancer, you still have to be on potentially medicine for that because you've got cancer elsewhere in your body. So here's an example of a patient with this is an MRI scan showing a large tumor inside the neck, just below the jaw, of what's something called a chordoma. And this tumor is very big and it wraps around multiple vessels in the neck. And the goal, if you really want to take this out surgically, is you got to get out in one piece. This tumor cannot be taken out in pieces. So, like anything, I'm sitting at a desk. If this desk has to be brought through the doorway in one piece without touching the edges of the door, it's harder than if I can take it in pieces and hold each piece in my hand as I walk through the door. So the surgery becomes harder and therefore more dangerous potentially. But the goal is if we can get this tumor out completely, we can potentially cure this patient. So this patient, and here's another picture showing that it's wrapped around one of the vessels, and this red circle shows that that vessel has to be mitigated. This patient had a 3-stage operation. We went through the back of the neck and the front of the neck because we had to release the tumor where it was touching the back, we had to release it where it was touching the front, and then we had to lock the person in place with screws and rods, and then we can get a tumor that comes out in one piece with negative, what we call negative margins, meaning that when we look at the margin under the microscope, the edge of the tumor in the microscope, there's no tumor cells. So we've completely gotten the tumor out with clean tissue around it, as opposed to cutting through the tumor and leaving a bunch of tumor left in the patient. And because in this case, those tumors are very fertile, and wherever that tumor was left will grow a new tumor or multiple new tumors. And here we can see, this is the patient with an x-ray looking to the left, and you can see how much of their neck was removed, how much of their spine was removed to get this out in one piece and stabilize. And this is a gentleman I've known for years who is actually works in a hospital, and he works full-time, and he plays sports, even though he's had this, and he, so far so good, knock on wood, has shown no signs of recurrence. And so here's the picture of the tumor, and you can see, I'm trying to show how it looks almost like this specimen inside the patient. It was removed just like it was in the patient, as opposed to what a lot of neurosurgeons and orthopedic surgeons do is they take it out in pieces so they don't have to disturb the other tissues. But again, as I told you in this case, local control depends on getting the whole tumor out. And this is the case for chordomas. Debilitating deformity, this is what I said that before, that if you took the tumor out and said we got it out and it wasn't pushing on the spinal cord, great, and I don't have back pain because I'm not broken anymore. But if you leave me bent over with my head down or my body shifting off to one side, I wouldn't be very happy. Especially if you cured me and I was like this for decades and decades, I wouldn't be happy with this. So deformity, we've borrowed the deformity from the other side of spine surgeons, which I'm one as well, from scoliosis surgery, really from patients who are twisted or bent, and we said we should treat all patients with the lessons we've learned from cancer and the lessons we learned from scoliosis surgery. And here's a famous paper that talks about the impact of scoliosis on a patient or deformity. And let me just show you these pictures. So on the far left, we have a patient, maybe me, maybe one of you out there, who has a small scoliosis. Maybe this was picked up in school as a teenager, never had any surgery for it, never had a brace, or maybe had a brace. And what I'm saying is this patient has a small curve in their spine, but it's hidden by their skin and their clothes, and you don't really see them bent forward. And if you ask this patient how they're doing on a number of questionnaires we have, they will say, I'm normal, as you see down the bottom, function for my age. I'm no different than anyone else who doesn't have this deformity. The middle one, however, this is what we call a decompensated deformity, meaning that the patient is trying their best to stand up straight, but their spine is pushing them forward and they're bent forward all the time. And leaning forward all times, if anyone you want to try, leaning your back forward and pitching yourself forward for 5 seconds. I mean, this is really hard stuff. I hate doing it myself. If I have to lean forward and reach for something, eventually I got to say, give me a break. My back is killing me. Well, these patients are stuck in this position. And it's so debilitating for them that they don't stand up much. They don't walk much. They don't chop. They don't stand at the sink much. They don't brush their teeth. They try to brush their teeth sitting down. And they don't cook and all these things. So it ends up that if you ask them how their life is on these questionnaires, they have the same function as someone who has an amputation, no leg, working at less than a 25th percentile. If you go to the far right with this person who's not only bent forward but bent to the side, so they're leaning off to one side, their head is all twisted, there is no disease correlate for this. We'd have to add up the disease correlates. Their life is so disruptive to them that they actually, the comparable state would be someone at the very bottom right. Comparable disease state would be someone who's blind with an amputation and has lung and heart failure, to get the amount of suffering that they go through because they're twisted at all times. So again, if we give someone this gift of helping them through cancer, and we say, we got it, and we've got you stabilized, and your legs work, and your back is solid, but they're twisted and bent forward, it's not going to be ideal, right? So this is something we think about. And for the sake of this discussion, we have all these parameters, just like the last one I talked about with stability, and we've spent these, and these were based on doing studies and doing research to show what really drove patients to happiness and to sadness. And we looked at these numbers and tried to think of the best numbers. And see there's some of these, here's some of these numbers, but it gets very complicated. And here you talk about the cervical deformity, and this is not meant to read, but you can just see all these little modifiers, all these little blue boxes that we said we want the patient to live in these areas. Because if they live in this sweet spot, we find that 1 million patients before them had been happier if you got them in these sweet spots and unhappy if you didn't. And this is where the research and the experience of surgeons who do this is helpful to the patient and their family. So do patients with tumors get deformity? Yeah, well, here what happens. Say you have a fracture and it's in a straight part of the spine, it collapses kind of like a soda can if you stepped on a soda can. On the other hand, if there's an angle to the spine and it collapses, it can collapse sideways, and again, you can be leaning forward or leaning off to the side when that tumor fracture happens. And so here's an example of certain parts of the spine where you can see that one little area of white where this has kind of been collapsed down. All these squares above and below look normal. And this is one where it's like I said, stepping on an empty soda can. Same thing down here. However, at this one, this patient is starting to angle. And this is an area of the spine that is a little more angled to begin with. So if the fracture happens and you drop gravity on someone and it happens to be an angled, the gravity is going to force them in an angled way, as opposed to an area that's straight that maybe just collapses straight down. And so we have to be wary of this. This is especially important in the neck. The neck is more flexible than the lower back. And we all know that we can turn our head around and we can bend forward and backwards, much more flexible. And that's good. As I always say in anything, and definitely in this talk, there's a trade-off of that. If some of the elements of the neck are broken, the neck becomes extremely unstable, right? It's already flexible to begin with. And so if some of these areas are broken, the neck can become very unstable, and that can be catastrophic. In other words, if the broken bones in the neck, they can have what's called a subluxation, where the spine just doesn't crack to one side or the other. It actually slides completely, and that cuts off the spinal cord and compresses it. So it can be a very, very big deal. In addition, sometimes the surgery itself can cause deformity. And so if surgeons and their planning is not correct, we can actually create a new problem. So for example, taking out a tumor and doing the smallest operation possible, taking some of the covering of the spinal off to get to that tumor, if we don't reconstruct that with screws and rods, sometimes it can be a problem. So here's a paper we wrote years ago showing this, and here's a 23-year-old, super fit 23-year-old, but she's got a spinal cord tumor. Okay, the tumor is in her spinal cord, not in her bony spine, but in the tube that goes from your brain down your spine and gives off all the nerves. And this is a very scary thing because this tumor can cause paralysis if left untreated, but the surgery itself can be risky because you're cutting into the spinal cord. So this lady undergoes the surgery and it goes great. This is done by a colleague of mine, and she underwent a wonderful procedure where she was left with good strength in her legs and the tumor was out. But in order to get to that tumor, they took some bone and they said, let's not worry about it. We took some bone and she can handle it. But over time, because they took that bone, her head started falling forward and falling forward. And every time she had a picture, the staff and the radiologist would say, your spinal cord tumor never came back. God bless you. It's gone and probably gone forever. And she'd keep saying, how come my head keeps falling forward? She's 23 years old. It got so bad that as she fell forward and really her posture changed, she actually started complaining of low back pain. Low back pain because in order to pull her head up, which she couldn't do, she ended up using her lower back to pull her head up, and she overextended her back and said, my lower back pain is driving me crazy, and trying to pull her head up off the ground, if you will. And so this is a 23-year-old. Obviously, she might be cured of this tumor, and she's doing great, but she's really unhappy. So deformity is one of the major aspects. And here we can see X-rays of her, and suffice to say in this picture, she's really extending her lower back to make up for the fact that her head is forward, and that causes significant debility. And here's some numbers to show that. So this lady needs to undergo a much larger operation to here you can see the MRI and the CT scan showing the area of the spinal cord resection, and one can see where the bone was taken on the CT scan, and right in that area she's falling forward significantly. So this lady, as I was alluding to, needed a much bigger operation where we need to go in the front and the back of her neck to really loosen up her neck, because it started to set in that way. It started to become fixed in that position, and we had to now unfix it and basically re-break her neck from the new position she had and reset in a new position that she liked. That probably could have all been done in a much smaller operation, just replacing some of the bone that was taken away. But once they get a deformity and it's long-standing, it can be big. So thinking about this in real time is key. And she's doing well now. She flew back to Colorado, and she's active both athletically and her job. She was in school at that time I operated on her. There's another case of a patient who has myeloma. Now, myeloma is a condition, as I alluded to before, that can respond very well to radiation. But this patient came in with significant weakness. So they went through surgery and said, we got to bring this person to the emergency room, bring this person to the operating room emergently, and decompress them. And that was the right thing. And it was the right thing. However, it wasn't enough. And the idea was that they were so excited about decompressing and saving this patient's legs that they said, let's just get them through this. They have cancer. We'll radiate later. The tumor's probably sensitive. And who knows if they're going to be around that long. So let's just do what we can today. But these myeloma patients can be cured in some cases. All right? So doing the kind of quick and easy and saying, let's just live to fight another day, sometimes while you're there, as a surgeon, we should do more. And so, for example, this patient underwent that surgery and woke up, thank God, with good strength in their legs. And it was radiated because this tumor responds to radiation, so they wanted to not only take the tumor, but radiate and say it's off, it's gone. And here's the picture of the patient with the bone gone from where they did the decompression in the upper thoracic spine. And about 3 months later, again, remember this patient was radiated in an area that might have already been weak. This patient fractures through their area that they operated on. Similar to that young girl where she kind of slid into her deformity, this one just broke. And so now we're sitting here saying, wait, we rushed to do the surgery, which probably was, from a surgeon's point of view, about an hour-and-a-half surgery. And if they put screws in at that time, maybe it would have been a 2.5-hour surgery. Now this surgery is a surgery that takes about 8 hours to fix, and the patient has to go back through this. And so we now have to reconstruct the spine because it's been broken and settled into a new position. So again, thinking about deformity at the same time as compression on the spinal cord, cancer control is important because we don't want to have to be back. And so these are things that we always want to try to think about. And so this lady here, her CT, again, you can see on the right side all these nice little vertebral bodies, but in this one area the things are fractured. Those were normal, relatively normal when we first saw the lady, and so if we kind of fixed her in that position, maybe it would have been stable, but this fractured, and now it's a bigger surgery, and this is the type of surgery needed with cement and screws and a cage of metal to really reconstruct that. The patient did really extremely well, is still in remission from her cancer, but again, had to go through 2 major surgeries instead of maybe just 1, because sometimes we don't think about deformity, so it's something to think about. The final thing I'm going to talk about is survival satisfaction. Again, remember, we don't want the surgeon or the doctors, and I'm one of them, but I'm also a patient too, saying, you know, you got a great procedure, and you're going to do great, and trust me, you did. And the patient goes, you weren't listening to me. I didn't want all this. I wanted just to have this, all right? You didn't really address my other issue. So it has to be a team sport. And so we've looked at this, who benefits when we think about predicting post-operative quality of life. This is a paper we wrote together recently. And some of the things are obvious, right? If the patient comes in really healthy, they're going to probably be healthier afterwards, or if they're really sick, it's going to be harder. Baseline function, you know, can they walk? If they can't walk before surgery, the ability to make them walk after is harder than if they could before, and any neurologic function. All right, so those are some simple things, but what I'd like to talk about for the last couple minutes is the idea of quality of life. Really, a lot of us, and you can think about what this means to you, but I would challenge you to think it really is, at least in patients' terms, and I think in any term, the discrepancy between expectations and experience, right? We're disappointed when we expected something to be better, whether it be a dinner, a relationship, a job, or our care in healthcare. And so, for example, if you are a patient who walks with a cane, and your expectation is you're going to walk with a cane after surgery, and then you experience walking with a cane after surgery, your quality of life, you'll be relatively satisfied. This is what I thought was going to happen. If, on the other hand, your expectation is that you're going to run the first marathon of your life after surgery, and you've never run one, and you still walk with a cane, you're going to be unhappy. And so this is the idea of expectation management, that we have to do for each other, because we're all trying to help each other out in life, no matter where we are. And doctors and providers have to do this for their patients, especially with spine tumors. This is the expectation. Sometimes it's hard to hear. It can be given with hope. It can be given with love. But it has to be realistic. So the patient says, I had no idea after surgery it was going to happen. He said, oh, I didn't tell you that? It's very disappointing afterwards when people hear that. If it equals the expectation, they're happy. If it doesn't, they're unhappy. And this is the idea. This is a graph, and I don't want to be too confusing on these last couple slides, but the idea here is that utility is happy faces. Just use the word happy face for utility. And you're at a certain height. And as you go through time, as you go left to right, when you undergo a treatment, and the treatment, say, is radiation, you take a hit, no doubt about it. But the hope is that that gives you some benefit, and that benefit is lasting. Now, eventually, we all pass away. And of course, as we get closer to the end of our lives, our utility goes down. If you have surgery, the idea is that probably the hit is a little bigger than radiation. So the drop in utility, when they say, whoa, I went through a lot more for this one, I'm more unhappy faces with surgery than I did with radiation. But hopefully with surgery, in most cases, that gives a longer runway down the road. So we're getting more bang for our buck, just like any investment. If we invest a little more, we hope we get a little bit more investment. And then obviously, if you do two things at once, radiation and surgery, which is the classic treatment for a lot of tumors, the hit is a little harder. They have to go through two procedures, but they might have something that's durable, and it may be long-lasting, may be curative. And that's why this line doesn't drop at any point. And that's really what we're doing. So this paper we just wrote just a few months ago was to operate or not to operate, and really a review of the role of predictors. So as you all know, if you watch, say, Netflix, which I have no relationship with, and you look up your Netflix, it'll say recommendations based on what you've watched previously. Those are all algorithms trying to predict you. If you surf on social media, it'll give you ads, and you say, that's funny, they advertise the exact thing that I buy for my dishwasher. And you think your phone's listening to you, but really it's you've been purchasing things and that data's in, and they're putting into an algorithm to predict how you behave. And what we're doing is we're using this in spine tumor patients. And we're trying to say, we've looked at thousands of patients, and we think in your case, you do this well, or you do this well, and this is why we'd recommend it. And we've looked at calculators and predictors. And this is the idea, is that we take information from the patient, we take information from their medical records, from their lab values, from their x-rays. We use artificial intelligence to look at things that maybe we don't see. We use experience, we do some models, and we put into situations, and the goal is, if we can put all those things on the right, the electronic medical record, which is a thing that helps us follow patients, imaging, outcomes that we've studied for years, and I've studied for years, financial, what does that mean? That means, is this efficient for the patient? They spent 5 doctor's appointments, saw each one of them, they drove to the place, whether it be financial or time, it doesn't matter, it's some cost to the patient. How come we have to make them go through 8 million hoops of fire? All these things are put together, and then we can create models. And then this doesn't decide it, right? We're not asking Peter to decide. It just gives us the best information possible so the patients and the physicians together can say, based on everything, it's looking like this is the best option. And that's constantly evolving. So at the end of this, what I'd like you to take home is it's multivariables, multiple things we have to think about, just like a relationship, just like a job, just like a sport. You can't just look at the baseball. You got to think about where your feet are. You can't just think about your relationship and said, I take my spouse out to dinner once in a while. You got to think about other aspects. You can't think of your job. They pay me. There's other aspects of it. Just like this, there are about 5 aspects that we're constantly thinking about. And all of them have to be thought. This is a great book of which I've read. It's called The Wisdom of Crowds. And this really, to me, is about teamwork. Even though it's really about crowdsourcing information, to me, it represents teamwork, because the more educated people we include, whether it be a sarcoma board, a spine tumor board, patients themselves, my colleagues, my mentors, my students, asking them their best thoughts on this, and then putting that together, we find out that's much better. In the old days, it used to be some self-proclaimed expert would say, I know the answer, and some self-proclaimed expert, someone else say, I disagree. Now what we do is we get together much more often so the patient benefits from all these aspects. And then again, we kind of put this together. So here's a book that me and a number of colleagues put together on spine tumor surgery that is technical, but obviously people can read. And if you have problems sleeping at night, obviously you can start reading it. Maybe that'll help you put to sleep. But the idea is that these are all resources that you have. And finally, I'd like to thank you on behalf of Northwell Neurosurgery, on behalf of North Shore, where my main office is, which is on Long Island. But really, we are looking at spine tumor treatment across our entire system. And that system goes all the way out to the east tip of Long Island, through South Shore and Peconic and Huntington, through North Shore, LIJ, Cohen Children's, and the cancer centers, in the central, all the way out to the east, I'm sorry, to the west in Lenox Hill and Manhattan, Staten Island University Hospital, and Northern Westchester Hospital, and Phelps Hospitals, where we are doing spine tumor surgeries on a regular basis. So on behalf of all of us and myself, I'd like to thank you for your attention, and good luck and God bless you. Thank you.